Hi, good evening, everyone. So it's been an honor, and pleasure to kind of learn pulmonology about, from the stalwarts of pulmonology. So I'd like to call upon on stage Dr. G.C. Khilani, sir, to conduct the following lecture.
This is proud to introduce Dr. Khilani because I looked at his credentials and he has been fellow to Mount Sinai School of Medicine. I happened to be there for few months, so it's good to know that he's also ex. And probably this was the mainland or it was the Mount Sinai at the Manhattan, sir? Dr. Khilani?
Manhattan, sir.
Yes, Friedberg was there as a cardiologist, very famous cardiologist of his time. And there used to be a couple of people, Nobel Prize winner at that institution. He served as adjunct committee co-vaccine trial, member expert committee of ICMR on electronic cigarettes, fellow of National Academy of Medical Science, has been chairperson North Zone of Indian Chest Society and past president of National College of Chest Physicians. And Dr. Khilani is a chairperson of PSRI Institute of Pulmonary Critical Care and Sleep Medicine, and formerly professor and head department of Pulmonary Critical Care Medicine, AIMS, New Delhi. So, equally important is drug-induced fibrosis, methotrexate. Methotrexate is the one drug which is used as an antifibrotic in rheumatoid arthritis, collagen disease, but it also induces fibrosis. And we have a lot of patients who have been getting this puzzle because of the methotrexate use. At a time, it's very difficult to hold on them because they can go back to the original disease once you stop them. If you continue them weekly, and they also ultimately lead to the resurgence of the condition. Till then, can we have extempore, Dr. Khilani?
Sorry, yeah. So, good evening, ladies and gentlemen. At the outset, I want to thank Dr. Pathak for bringing me here. It was actually long overdue, and the topic he has given to me is close to any pulmonologist. फिर क्या होगा? So, when I joined All India Institute of Medical Sciences, Respiratory Medicine, I was in the Department of Internal Medicine, practicing respiratory medicine in our chest clinic. Rarely I got a patient with ILD who was not treated for tuberculosis. What I want to say that awareness was very little. ILD was equated with IPF, idiopathic pulmonary fibrosis. That time Murray and Nadal, which is my Bible, it also read that if the person has ILD, treat him with 1 to 2 milligram per kilogram of prednisolone. We have come a long way. We have come a very long way in this disease, and that is what I am being very excited to talk about it. As to there has been changes, and it took after 1991 that I joined. The first drug which was which became somewhat effective was 2014, when nintedanib and pirfenidone were both approved at the same time in the 2014 in the month of May in American Thoracic Society conference, where I was physically present there, and pulmonologists were ecstatic about having a breakthrough in the management of interstitial lung disease. So, and of course, the connective tissue diseases and ILD involvement and so many other causes of interstitial lung disease that I am going to talk about. What is important is that in ILD, that it's very easy to give drugs, but it's very tricky to manage it. When we are rarely able to stop it, but I would think that sometime we need to stop medication also, because all medications are toxic. They cause side effects. So everything in the medicine boils down to harm and benefit. Where the ILD becomes very important. Running a ILD clinic at the All India Institute for several years, if I had 4 patients of IPF consecutively, I used to be very depressed. Because majority of patients would say that I am not better. I am getting incessant cough, I am short of breath, I am on oxygen, and that is how it goes. So I think all is set. So this will work, this mic? Or? Sorry, ladies and gentlemen, electronic goof up despite 5, 6 laptops here. We are here, so please bear with me. So, what I am going to do in next whatever time provided to me is to give you a bird's eye view. I have already given you an introduction that ILD is not one. So what I have done is that I have prepared 5 cases, and the subject of ILD requires 10 lectures, 15 lectures, separate on radiology, separate on each diseases. So what I said that IPF was thought to be the, so if you all could be quiet, I'll be able to speak. There's a lot of people talking at the back. So everybody thought that IPF was the most common interstitial lung disease, but this Indian registry actually showed that it's not that hypersensitivity pneumonitis was the commonest. And one of my colleagues said, "Kabutaron se dur raho." And that is what has been exemplified in this hypersensitivity pneumonitis and then connective tissue disease. And third comes IPF. And there are several other causes, goes up to 200 causes of interstitial lung disease. So I have prepared my presentation by showing you 5 cases, and you have to be concentrating on the screen. And this is a 66 years old gentleman, hypertensive, smoker, symptoms of progressive dyspnea, recent limitation, occasional wheezing suggestive of asthma. And this was the X-ray. If you see this X-ray cursorily, you had an amazing lecture. You might think that this patient has chronic obstructive pulmonary disease. He could be having congestive cardiac failure. He could be having lung disease. So PFT was done. Or should we do a 6-minute walk test, or should we do a CT? So what I am talking about, a clinical approach to a patient suspected of interstitial lung disease. So you have to take a detailed history, you have to do a radiology, you have to pathology. So it has to be a multidisciplinary approach with a physician, pulmonologist, radiologist and pathologist to achieve a complete diagnosis. So you look at the age. Again it stopped moving. It's moving here, but it's not moving there. I think I'll postpone my lecture. There's no point in. Okay. So you look at the age. If the age is more than 55, you think of IPF, young female, CVD, sarcoidosis. You have to gender. If the female, you more think about LCH and connective tissue disease. Sorry, in the male you think LCH and connective tissue disease. The female you think of LAM, sarcoidosis and CTD. Smoking is related to RBILD and DIP and PLCH. Similarly, exposure history. So I have to go a little fast to save on time. Similarly, the family history is important. You can read all these causes and other symptoms. Especially if the patient has hemoptysis, you think about Gush-Pasteur syndrome or Wegener's granulomatosis. If there is a pneumothorax like kind of a situation, you think of LAM and LCH and pleural. If there is a pleural effusion, you think of rheumatoid arthritis and SLE and GRD features and CTD. If you look at the PFT, how does it help in diagnosing? This is the diffusion capacity and now 6-minute walk test that I rely on for this. In the PFT, from the PG's point of view, the vital capacity goes down, the ratio will be normal or it will increase. The diffusion capacity will surely go down, the total lung capacity will go down, and alveolar arterial oxygen difference will be increased. Now, there are certain ILDs where there may be mixed, there may be airway obstruction like you have in COPD, like hypersensitivity pneumonitis, RBILD, LAM or LCH and sarcoidosis. So, how does the radiology help? And now I would like to draw your attention on this particular. Now, when you have a normal CT appearance, this is a normal CT, there is an interlobular thing, there is interlobar, there is subpleural. So, you need to understand the anatomy of interstitium. Now, this is a very clear picture of what you are looking at. This is the acinus, this is the lobule, and what is important for you to understand, what is interstitial thickening, what is the secondary pulmonary lobule. And this is another picture. When the radiologists tell you there is a centrilobular nodule, there is a perilymphatic nodule, this is what it means. It is a centrilobular nodule, these are the perilymphatic nodule, and there are certain diseases where particular type of nodules are present. Now, there is a pattern based on the approach to the diagnosis. There are 4 general patterns. There are nodules that you can see here. There is some almost like a tree and bud like. This is a reticular opacity that you should be familiar with. There is an increased attenuation and there are areas of decreased attenuation. On a HRCT, you have to sit with your radiologist to understand. Similarly, there are nodules which are bronchovascular, peribronchovascular, which are classical of sarcoidosis. There are fissural nodules and there are subpleural nodules that you can see is classically seen in sarcoidosis. So, it is important and there is the areas of traction bronchiectasis and honeycombing, which I will be talking about. So, talking about it, now coming back to the case that I was discussing, an elderly male who had this kind of X-ray. Now, I have done a CT scan. Now, without telling you, if you see here, there is interlobular thickening, and this is septal thickening. If you look at the lower part of it, and this is what is, there is a bronchial valve thickening, that means tracheal bronchiectasis, and this is what is called as honeycombing. All these things you should recognize if you want to diagnose interstitial lung disease. To my mind, in majority of time, except a few which I will be telling, it has replaced histopathology. Now, there are some blood tests which are used very commonly, which you should know: ANA and dsDNA, anti-CCP and RA, NCA, JO1, SCL70, ACE for sarcoidosis, and CBC and AEC for eosinophilic pneumonia. Now, in this case, continued further workup. We had no comorbidities, no history of occupational lung disease, no history of drug-associated ILD, no ANA and RF was negative. So, the diagnosis was ILD, UIP pattern. Most common diagnosis by exclusion is idiopathic pulmonary fibrosis. This patient does not require any biopsy. So, this was case 1. The lung biopsy is done in certain cases, which could be by bronchoscopy or and BAL. bronchial biopsy or transbronchial lung biopsy, and now transbronchial cryobiopsy has almost replaced surgical lung biopsy and VETS biopsy. Open lung biopsy is a thing of past. HRCT is the one which is helping us. Now, as far as the treatment is concerned, Dr. Rajadhar will probably be talking in. So, there is non-pharmacological treatment in terms of smoking cessation, pulmonary rehabilitation, vaccination, oxygen therapy. There is a lung transplantation, of course, is the final answer, but the pharmacological treatment is the thing which is, as I said at the outset in the introduction, in the year 2000, the steroids and cytotoxic drugs were used, and subsequently steroid with cytotoxic with N-acetylcysteine was used, which was also dumped by the Panther trial, and then etanercept, bosentan and sildenafil and all drugs were used till the time these trials came and pirfenidone and nintedanib was used. Both drugs are still being used. Initially they documented, they reduced the decline in FVC. No drug so far in IPF improves the vital capacity. They reduce the decline, but there is now sufficient evidence that they improve the survival also. Similarly, nintedanib also has shown to be. Now, what has changed? I will be coming to it that initially they were approved for idiopathic pulmonary fibrosis. Now they are approved for all fibrotic lung disease based on the census trial. Now, case 2 is a 51 years old male, diabetes type 2, hypothyroidism, progressive dyspnea for last 1 year, currently MMRC 3 since 6 months, early clubbing, bilateral inspiratory crepitation, connective tissue markers were negative, vital capacity was 45%, diffusion capacity 46%. Now, this was the CT. If I could ask Dr. Richa, what do you think? Is it a UIP pattern or an NSIP pattern? She'll be quick because she is an expert. But you look at it, there is peripheral sparing of these shadows. There is some ground glassing, there is a traction bronchiectasis. So, if you look at it, this part is spared. But when you do the other cuts, there is some amount of honeycombing making in the upper lobe. So, is it UIP or is it NSIP? Now, these are the cases where the biopsy is required. So, this case underwent a biopsy and diagnosis of UIP was made. So, very rare cases, a biopsy would be required. So, this diagnosis was UIP, IPF, so lung biopsy required in very, very occasional cases. Now, case 3. Case 3 is a 34 years old lady, skin tightening and upper arm for 1 year, Raynaud's phenomenon, GERD, dyspnea, SPO to 95%, vital capacity low, loud P2. And this is written, this is a case of scleroderma. Now, scleroderma has a very high incidence of ILD. If you do the autopsy study, almost 100% patient with scleroderma will have some evidence of ILD. So, this was the CT of this particular lady. This is a classical NSIP pattern. Now, here comes the value of extractable nuclear antigen. All patients with ILD must go have an ANA and RF. That's what I practice. If the ANA is positive, you can go ahead and do quantitative ENA profile. If the SCL70 is positive, it is very sensitive and highly specific for scleroderma. Not every patient with scleroderma will present with florid symptom features of scleroderma. Sometimes the ILD comes first and the connective tissue disease will come later. So therefore, the criteria for diagnosis are thickening of the skin and all those things, but then the lung manifestation of ILD are NSIP most common, UIP, diffuse alveolar damage, cough, that is organizing pneumonia, pulmonary hypertension very common, PH and PH could be primary, it could be secondary to advanced interstitial lung disease. Now, drug therapy for PSS related ILD I will be touching upon. Initially, the scleroderma 1 trial showed that cyclophosphamide as compared to placebo led to better outcome. But scientists always look for better options. So they looked for mycophenolate mofetil and then compared with scleroderma 2 trial. What it showed that there is no difference in the efficacy. But the adverse effects were much less with MMF. Therefore, as of now, the MMF is preferred. But that's not enough. There are other drugs also, cyclophosphamide, MMF, methotrexate can also be used, but rituximab is coming up as an important drug for that, and of course the stem cell and this is of course an investigational thing. So therefore, there is a lot to do in CTD related ILDs. Now, is there a role of antifibrotics in non-IPF ILD? That is a question. And this was answered by the census trial which came in 2019, nintedanib for systemic sclerosis associated ILD. This was a randomized trial with 576 patients, and it clearly showed the decline in force, vital capacity was much less, 41 ml per year was the difference between the nintedanib and no nintedanib. Of course, the MMF and other drugs have to be given. Now, case 4. Case 4 is a 63-year-old man, gradual onset progressive dyspnea with wheezing since 1 year. PFT suggestive of mixed pattern with reduced DLCO. 6-minute walk test was 300 meters with the lowest SpO2 of 86%. Symptoms correlated on pointed questioning, and this was the CT scan. Now, this is almost 25 years back that I saw, and I was unable to diagnose, I must admit, at this point of time. This patient underwent an open lung biopsy at the All India Institute of Medical Sciences, and it was diagnosed hypersensitive to pneumonitis. And today, if I show it to my senior resident, he'll immediately say, this is HP. And he actually did that. So this tells me my learning curve. There is a ground glassing opacity and classical head cheese appearance that you are seeing. So in this is the most common. This man was a bird fancier from Jaipur who took 6 months to get rid of his because there were no takers. They had symptomatic improvement, and 25 years down the line is still alive, working. He is a journalist by occupation. So therefore, it is very important. The overview of pathogenesis of HP is that there is antigen exposure, there is immune complex mediated injury, which leads to lymphocytic infiltration and then subacute granuloma formation, fibrosis. This is absolutely diagnosable, manageable disease with amazing outcome. If you go to Google, every ILD patient reads and comes to me that my life is only 3 to 5 years, what will happen to my children and all, but actually I am following patients for 20, 30 years now, which are doing reasonably well. So diagnostic criteria of HP are given in front. There should be known exposure, but that's always not true. There should be bar lymphocytosis. There is a compatible histopathology, and this is one condition where transbronchial lung biopsy will help. The bronchoalveolar lavage will help if it is necessary, and of course we do HP panel, what is hypersensitivity pneumonitis panel, which will help. The drug treatment for hypersensitivity pneumonitis is steroids. If persistent symptoms are there, you can treat with MMF or azathioprine, or some people have also used rituximab, but I don't have any experience with that. This is the last case. 45 years old lady, diagnosed case of diabetes mellitus, hypertension, dry cough for 1 year, no medical attention, history of acute cholecystitis. Montus test was 0, ACE was 114, normal serum calcium. She had calciuria, and PFT is showed restrictive, and this X-ray is not the best X-ray, but you can see a right paratracheal shadow and left hilar shadow. So This was the CT scan. You can see a large mediastinal nodes, subcarinal nodes, and also right paratracheal nodes, and some lung shadows also. They are not the best for. So what next? So we did a lavage with transbronchial lung biopsy for sarcoidosis. The bronchial biopsy has a yield of 60%, TBA LB a yield of 60 to 90%. The cryobiopsy will not be required, and it showed non-necrotizing epithelioid cell granulomas. There could be several other things with sarcoidosis, that is papular sarcoidosis, subcutaneous nodule, erythema nodosum, lupus pernio. So the initial treatment, the sarcoidosis is one drug which has amazing outcome. And when I was doing my MD long time back, I didn't see a single case of sarcoidosis. And today, in my OPD, it is one of the most common disease that I treat. I don't know why, like ulcerative colitis also I didn't see, and now it has become so common. So glucocorticoids, 0.5 milligram per kilogram are the drug of choice, which should be gradually tapered. Low dose steroids for a period of 6 months. You can also treat with hydroxychloroquine. Methotrexate is a good drug, and azathioprine is safer than methotrexate. There is nothing to choose between the two. So after 9 months of treatment, this was the CT scan, and now the question is, the sarcoidosis patient asked me, for how long do I take treatment? Can I answer that question? So I tell them one thing, that 50% of the patients will get rid of sarcoidosis without any recurrence. But this is how the routine things. Initially you give steroids, you taper steroid to maintenance dose, you continue with the maintenance dose, you again reduce the dose, you stop, and he gets a relapse in some or the other form. So this is one disease where you have to use all your knowledge and judgment to modulate the treatment so that you cause minimum harm, you give the best comfort, and try to stop. If you want to give a difficult topic to a pulmonologist, which I tell him, tell me when to stop treatment for sarcoidosis, and he will be in a tizzy. He says, "Kyun mere ko topic de diya? Isme to main kuch nahi kar sakta." It's a very difficult disease, but a very gratifying disease to treat. So, how do I compare methotrexate with azathioprine? They are equally effective. But we all prefer methotrexate because we have more experience. If the lady is pregnant, then I give azathioprine, otherwise my choice is methotrexate. The current treatment option for sarcoidosis are methotrexate, azathioprine, leflunomide, MMF. Disease progression is there, you can give infliximab or adalimumab. Rituximab is tried in all diseases, so in this also. Now, finally, I'll take a few minutes to discuss something which is very troubling to a pulmonologist. That is acute exacerbation of ILD. IPF, when they come to the ICU, when they get admitted, they are at the verge of getting ventilation. There is a 25% or 50% chance of death. That is the time intensivist, which I am in trouble. What to tell the attendant? What can we do about it? The acute exacerbation of IPF is defined as acute clinically significant respiratory deterioration characterized by evidence of widespread alveolar abnormality. The incidence varies between 7 to 32%, and current evidence suggests that up to 46% of deaths in IPF are associated with acute exacerbation IPF. In hospital, mortality is something like 50%. That is what my last part of my... Now this is the graph of lung function. When a person gets IPF, his vital capacity keeps on going down. Every year 5 to 10%, if he gets an exacerbation, it comes down, it further comes down. When there is severe exacerbation, it comes down like this. Can we do something about it? What are the risk factors? If the young age, if the associated coronary heart disease, if the BMI is high, if he is a East Asian, they are likely to be more. There is increased dyspnea. If there is prior history of acute exacerbation, he will get more. Increased KL6, we don't do this test. Surgery or lung biopsy is also. If the vital capacity goes down, if the DLCO goes down, poor baseline oxygen, these are all risk factors for this. So therefore, but you can't do anything to these risk factors. These are the most important factors. Now, how do I diagnose it? How do I say that it is not pulmonary embolism, it is not an infection? We have such a short fuse for giving highest end of antibiotics to the patients who are getting admitted to the ICU. So when the patient gets admitted, you have to identify the contributing factor. Do a D-dimer. If the D-dimer is high, if it is normal, which is very unlikely, have a low threshold for CTPA. If this could be congestive cardiac failure, for which you do echocardiogram and anti-pro-BNP. It could be infection if there is a leukocytosis or imaging shows, or use procalcitonin for that. If you look for pneumothorax, do an ultrasound, and if they look for a diffuse alveolar hemorrhage, and look for any triggers if are there. What is the role of HRCT in acute exacerbation of idiopathic pulmonary fibrosis? This is extremely important. And I have very low threshold for, this is a patient with IPF. When he gets an exacerbation, there is a ground glassing. Now this ground glassing could be because of infection, it could be pneumonia. So do you do a bronchoscopy? Be careful, be careful. If you do a bronchoscopy, if he goes on a ventilator, the chances of extubation are very little. So avoid doing bronchoscopy in such patients. So you have to do all your skills of a physician, astute physician, to manage acute exacerbation of IPF. What is the role of bronchoscopy? I have already said, but it's not that it should never be done. If there is a high suspicion of something, who knows that it could be tuberculosis? Who knows it's not a PCP infection? Who knows that something which can be diagnosed based on, but you try to use less invasive. What is the drug therapy? This is the last part. And before I go on, I'll just cite one incident that I was in an international conference, that is American College of Chest Physicians. There was a huge lecture on acute exacerbation of ILD. There were 4 experts who have done original research. They said this doesn't work, cyclophosphamide doesn't work, steroid doesn't work. So I got up to say in the end, sir, I come from India and I see a lot of ILD. When I get a patient of acute exacerbation of ILD, I treat them with steroid. Please tell me, what do you do? They said, we do the same thing. So this is where we are. When you are up against a wall, management of fibrosing acute exacerbation of ILD, to date no evidence-based effective therapy has been established. International consensus guidelines on IPF are only recommend supportive care and corticosteroid use. Other immunosuppressive therapies have not shown consistent benefit. Other experimental therapies include combination of immunosuppression, silvestrate and hemoperfusion. Supportive measures include management of acute hypoxemic respiratory failure. Now I will tell you my experience. If the person is not managed on oxygen, between the HFNC and NIV, I prefer HFNC. It is working better than the NIV. These patients are unable to tolerate, but that's only palliative. Systemic corticosteroid, high dose steroid use, if the person is not responding, my choice is pulse steroids, 0.5 to 1 gram. I give it for 3 days as a trial. I can't say it works all the time, but sometimes it works. And this is the basis of it. I think I have exceeded my time, so I am not going to read this. Now, steroid and cyclophosphamide can also be given in combination. There are only case reports supporting this. People have used cyclosporin with methylprednisolone, and they are only retrospective. There are no RCTs. In fact, whatever studies are there, steroids seems to be counterproductive. Summary. Summary is that the diagnosis and management of ILD requires a multidisciplinary approach. You cannot do it alone. You may not believe me that at least twice in a day I hop to my radiologist because I work in a smaller hospital and see the CT. When you see a CT scan on a film, it's entirely different from what you see on a computer screen because you're able to see the whole profile and take opinion of a radiologist and then of course pathologist if necessary. The various tests should be interpreted in combination with the clinical finding. The goal of treatment of ILD is to suppress the inflammation and prevent destruction of lung parenchyma. And that is the crux of it. Quite often, lifelong therapy and monitoring is required. Judicial use of medication and physiotherapy, which I have not talked about, improves quality and longevity of life. I am so sorry there were a lot of goof-ups, but thank you very much for your kind attention.
Any questions from the audience?
I would like Dr. Richard to comment on.
Yes, sir. One query only I would like.
Yes, sir.
Because we are working at the tertiary center of our place.
Yes, sir.
And the patients are coming after getting underdiagnosed, you can say, later stage, whether it is sarcoidosis. Most of the time, it is diagnosed as a tuberculosis. They took treatment for tuberculosis, even up to the MDR, because underlying pathology is sarcoidosis. And it comes to our center. So in case of any late diagnosis of ILD, any variety, whether it is IPF, HP, or the sarcoidosis, and patient ultimately diagnosed as any part of the ILD. And patient is already on anti-tubercular treatment midway. So how do you feel that he should go ahead with the tuberculosis or anti-tuber treatment, or when we should suddenly stop ATT and we should switch over to the any ILD? Number one question, sir. And end of the treatment, as you told, that acute exacerbation of, it is very difficult to manage and very difficult to decide what to do. So end of the treatment, is it not quackery in the ICU?
So all physicians are quacks like me. First and foremost, I always keep reciting this. Sir, your first question is easier. When I started my career in 1991 at the All India Institute of Medical Science, it was pretty often that we were starting anti-tubercular treatment empirically. Empirically means based on X-ray or CT scan and symptoms. And the study that I conducted under my mentor, Dr. J.N. Pandey, on hepatotoxicity, where I started my anti-tubercular drug, response to ATT was taken as a diagnostic criteria for tuberculosis. Even for study purpose, this paper was published in the Thorax. Today, with the availability of Gene Expert and Gene Expert Ultra, and with the diagnostic facilities, I don't even remember when I started anti-tubercular without a diagnosis, without a microbiological confirmation. So it's very, sir, easy, not so difficult to, and I have a low threshold for doing bronchoscopy in such cases. I do a ball and send it for whatever Gene Expert, and sometime if the suspicion is high, directly LPA bhi kara deta hu. If there is a MDR is suspected, the majority of time I am able to rule out. In that case, the anti-tubercular can be stopped. The second question which I did not discuss, the management of ILD has become somewhat easier with a term which is called progressive pulmonary fibrosis. That means even if you are unable to diagnose etiology of the interstitial lung disease, in your wisdom looking at the HRCT, if you think the person has fibrosis, interstitial fibrosis, which can be seen on CT, not by histology, and there is a decline in forced vital capacity or vital capacity, then this patient is a progressive pulmonary fibrosis. Your job becomes very easy because the two drugs like nintedanib or pirfenidone are approved and are very used for treating fibrosis of whatever etiology. So it becomes little easier. As far as the immunosuppressive like MMF or other drugs are concerned, that requires further investigation, of which ENA profile has helped us a lot, and also that HP panel. So I've sort of lived through it in last 35 years, and nowadays, one, that I'm not doing too many biopsies in these patients. I did in All India Institute little more than what I'm doing it now. And I think the management of ILD has come a long way, as I said, at the cost of repetition. Now the second question that you ask, what I do, and I'm not saying any evidence. If I am treating a patient, I do their test, that is vital capacity, diffusion capacity, and 6-minute walk test every 3 months. At the end of 1 year, I plot a graph. If the graph has become straight, I ask myself, is it important to continue with the treatment? Now that you require a courage. You require a courage to stop the treatment. And I do that. In patient with sarcoidosis, I do that. In patient with NSIP, I do that. But I must see that 1 year the patient has been totally stable. There is no ground glassing on the CT scan. And PFT and 6-minute walk test, I rely much more than the diffusion capacity. Because diffusion capacity has several intricacies of operator and technician and blah. A 6-minute walk test is rather straightforward. That gives me a correct thing that his oxygenation is stable, his CT scan is stable. So in the interest of the patient, I do reduce or oblique stop the medication, but follow them up after 3 months. Or with the symptoms, if the symptoms recur, I go back to. A word about corticosteroid, which you have not asked. Corticosteroids have million adverse effects. But now what I am telling you is personal. IPF, idiopathic pulmonary fibrosis, steroids have been dumped completely. Dumped means dumped. There is no evidence that they work. But in my experience, the symptomatic relief comes only with steroids, immediate. So I do give them steroids even if I know that it is IPF. For a short period of time, I generally give 0.5 milligram per kilogram. This is my personal dose, not from a book. And then I reduce it, bring it to 10 milligram. And if the person responds, I stop that.
Well, thank you so much, sir. Professor Khilani, we heard.
Thank you, Dr. Khilani. I would like to share one or two my comment, very small comment. As you know that many of you are chest physicians and physicians sitting here. And you have heard Dr. Khilani that CT is, especially high resolution CT, is one of the very important investigations to first diagnose ILD and then to subclassify ILD. And what we are seeing from these smaller districts, Dr. Khilani himself has confessed that he has to go to the radiologist very frequently to discuss about these CTs. And I believe when he goes there, he sees on the board and he sees every picture. So what I am trying to say, quality of CT is very important. And to improve the quality of CT, it is the duty of chest physicians also, of physicians also. You interact with your radiologist and say that if you are not doing CT the way it is required. Now there are guidelines how the HRCT should be done in the ILD. So meeting after meeting I say, and I usually advise my brothers and sisters, please interact with the radiologist, have a good CT, good quality CT, and especially if you have a volumetric film, then it is very important. Otherwise, many of the misdiagnoses what I have seen, even Dr. Khilani has said, a lot of patients of ILD, they receive ATT. And then we have not been able to even subclassify. Many of the biopsies can be saved if you have really a quality CT. What I'm trying to say in brief that probably we physicians and radiologists had to sit together, had to discuss, and make them that they will provide. अभी मैं देखता हूँ CT अगर कोई बलिया, बस्ती, बनारस से आ जाते हैं, एक प्लेट जो आती है उसमें 35-40 होता है. जब कुछ पढ़ने में नहीं आता उसमें देखने में क्या आएगा, समझ गए? So please make what guideline says. Hardly there will be 9 to 12 those films, but nobody is practicing. So unless we compel them, we discuss with them, and then they will definitely going to improve. Thank you very much.
Thank you, Doctor Sir. Thank you, Dr. Khilani sir. To present memento to Dr. Khilani sir, would like to call Dr. S.K. Pathak sir. Dr. G.C. Khilani sir, Chairman, PSRI Hospital, New Delhi.
So finally we heard that we are partly quack. Steroid तो हम लोग देते ही हैं, मरता क्या ना करता. Now we have heard Professor Khilani a very lucid talk. Now Dr. Srivastava will speak about the next speaker.